Hi, good afternoon. So my name is Dr. Sonal Bhakta. I'm the Chief Medical Officer at Mercy in Rogers in Northwest Arkansas. First of all, I want to give a shout out to Dr. David Deschamps, who was just up here on the panel prior. I was a very old, high-risk mother with my 2 pregnancies, and he was my MFM, and he did a phenomenal job. So I just want to give him a little shout out. At Mercy, our mission is to improve the health and well-being of our communities. We bring help to those in need, particularly moms and babies. We are committed to enhancing maternal health outcomes, and we're the only gold-level safe sleep certified hospital in the region. I said that correctly. So basically, we provide education prior to discharge for our moms to prevent SIDS at home. And I'd like to give a shout out to my nursing leaders, Whitney Tolbert and Dana Hadaway, because they're phenomenal for our moms at time of discharge. I am delighted today to be able to introduce the closing session of the 2024 Northwest Arkansas Health Summit, moderated by Olivia Walton, the founder and CEO of Ingeborg. This session features a distinguished panel consisting of members of the Arkansas Maternal Health Steering Committee. Please welcome to the stage, we have Olivia Walton, we have Secretary Renee Mallory, Secretary Kristi Putnam, Secretary Jacob Oliva. Is that right? Did I get it? Close. I really tried. Oliva. Okay. Surgeon General Dr. K. Chandler, Deputy Secretary Janet Mann, Deputy Director Cassie Cochran, and Dr. William Sam Greenfield. All right, well, thank you.
Thank you. Well, good afternoon, everyone. Thank you very much for being here today to join all of us for this very important conversation. I'm Olivia Walton. I have the privilege of being the board chair of Crystal Bridges Museum of American Art. I want you all to please come and see our special exhibition, Exquisite Creatures. I'm also an investor, I'm an advocate, and I'm a mom, which is my favorite job of all. My husband Tom and I live in Bentonville, and we have 3 adorable kids. They are 6, 4, and 1, and we really do look at each other all the time and say, I think we are in peak cuteness. So having had 3 kids over the past few years, maternal health has really been top of mind for me. I have seen firsthand some of the challenges in our healthcare system. I have seen some of the disparities of who has access to health and who doesn't. And with that, I've also seen some of the opportunities for improvement. So that is what we are here to talk about today. First, though, I really want to say how grateful I am to Governor Sanders for prioritizing maternal health. We are lucky to have a mom who is leading our state, who understands the importance of this issue. And yet, I hope we all leave here today more than ever being clear that maternal health is not just a women's issue, it is an economic issue. It is an issue for all of us. If there's one thing that the report from Heartland Forward makes clear, it is that investing in mom's health pays dividends. Not just for mom, but for our children, for our communities, and for our entire state. Now, the governor's order went above and beyond what me and my team could actually even hope for. And critically, it created this august steering committee, and I am thrilled to be joined by all of them on stage. So please join me again in giving them a warm welcome. So today is May 1st, and I believe you have 5 months now to get back to the governor with your recommendations on how to fix our maternal health care crisis. As of today, and it's summer too, 4 months, all right. As of today, we know it is a tall order. You've been hearing about it all day, but we are the top state for maternal mortality. In nearly half of our counties, there is nobody licensed to deliver a baby, and we have the 3rd highest infant mortality rate in the country. And we all know that these adverse outcomes are costing us billions of dollars each year. So that's what we're going to focus on, solutions and ideas to tackle the crisis. To start, could you each introduce yourselves again, please, and describe your background as it relates to maternal health here in Arkansas. So maybe Secretary Putnam, let's start with you.
Okay. Well, first of all, please call me Kristi. And so my role, I'm the Secretary of Department of Human Services, and we have the largest cabinet in the state as far as number of employees, but also budget, and we have a number of responsibilities. We have Medicaid, we have food assistance, we have all the public assistance programs, and but my responsibilities as it pertains to the work that we're doing here, I'm a mom, I'm a grandmother, I'm a woman, and we're very excited about the opportunity to work with incredible partners, not just here on the stage, but really across the state. We've already started. And so my responsibility is really to make sure that our team has all of the resources it needs to reach out and work with all of you, and we're super excited to be here. Thank you.
Thank you. And Deputy Secretary Mann?
Yes, it's
Janet.
Janet.
Okay.
I have a really long title, Deputy Secretary of Programs and the State Medicaid Director, which really means we provide all the services for child welfare, youth services, and Medicaid, which does serve almost 1 in 3 Arkansans, and over 400,000 of those Arkansans are children. So it's very important for children. And then Medicaid does cover over half the births in the state of Arkansas every year, which can range from 17,000 to 19,000. So very interested in how to better that prenatal delivery and postpartum care, and then to have healthy children to grow up and go to school.
Secretary Mallory?
Renee Mallory, Secretary of Health, and I represent the Health Department. And we have, thanks to Senator Irvin, y'all all know now, if you didn't know before, that we have a local health unit in every county, and community health is what we do. And I'll talk a little bit more about our maternal health services in our counties in just a little bit.
And Cassie Cochran, you're the Deputy Secretary of Health?
So I'm Deputy Director for
Almost.
Public Health Programs. It's fine. It's just Casey. That's it. So thank you all for being here today. And my role is the data side at the Health Department. We have a Division of Data and Analytics, as well as Division of Health Advancement, which encompasses maternal care, women's health care, and also the home visiting programs that we support. So local health units, Division of Local Public Health is also under my purview, and that is all the local health units around the state. So I'm very proud of that. That's the area that I came from, and historically was a director here in Northwest Arkansas for public health as well. So very connected to some of the special services and opportunities we have for the Marshallese and Hispanic populations.
Thank you. How about Dr. Chandler?
Hi, I'm Kate Chandler, current Surgeon General since, I guess, April of last year, so it's been about a year, and 27 years as a OBGYN, but I've just been doing GYN for several years now. Yes, I've been in Arkansas most of my life, Hendrix College and then UAMS, and so I've been very blessed to be at the clinic I've been for that many years and working with the group I'm working with. They still do OB, so I still get to hear a lot about their experiences. But yeah, I'm mostly serving, and didn't mention my favorite role, so I'm mom to 4 and Bubbles to 5. So that's my grandbabies, 5, 4, 3, 2, 1. But yeah, so right now I still practice. I've cut back some of my practice, but mainly serving as an advisor or Surgeon General. And on this task team, mainly, just working with everybody, but also I'll probably be most involved with the education part and outreach. And so it's just been really, really great to be here and hearing from the doctors panel, the women's panel, but it's been very, very enlightening and exciting to hear and working with everybody up here.
Dr. Greenfield?
Sam Greenfield. I am a practicing OBGYN at UAMS for about 20 years, and I serve at the Department of Health as well. Most importantly, as it relates to this, I serve as the chair of the Arkansas Maternal Mortality Review Committee, and I've served in that capacity since its inception. And through that work, we've been able to provide some information to drive this conversation to bring us to where we are today.
Secretary Oliva?
So you just call me
Did I
Jacob.
get it right?
It's Jacob Oliva, but I do think it's fitting for you to know that I've been called Jacob Olivia my whole life, so I'm really honored to be on stage with an Olivia right now. So this is a big moment for me. But I work for I'm the secretary for the Arkansas Department of Education, and when we talk about education, that's one of the outlines that was in the executive order to say this is not just about awareness and a campaign to make sure people are aware of access to high quality benefits or programs around there, But we also think about education, about what are we teaching in health education, and do we have the right standards? Do we have the right courseworks? How do we make sure students are prepared for the realities of life? But another part of what we work on that sometimes needs to be part of this conversation is we also work in the early learning environment and working with communities about access to high quality childcare in early learning opportunities is something that we want to do a better job of, because there's a reality that there's deserts and islands across the state, and then making sure that people are set up for success post-secondary. So we're excited to be a part of this initiative as well.
Great. It's great to have you all. Because there are so many of us, I just actually want to ask, everyone's microphones are working? Great. Okay, I wanted you all to explain what your roles are, because I'm hoping that after this, I'm sure that everyone in this room has some great ideas for you, and now then you can walk up, now you know who to walk up to with your great idea. Let's start perhaps with Dr. Chandler. So, as a doctor, can you help us sort of diagnose what our biggest hurdles are here in Arkansas? What are sort of the unique risk factors for us in a rural state? What do you think are our biggest challenges to fixing this?
Well, as has been said several times today, really just having access, having enough people providing care. In a rural, like we said, 35 counties don't have anybody to deliver the baby, so it's a maternal, desert. And if you look at, like, I've just kind of compared sometimes, maybe that comparison is what's the thief of joy. But anyway, looking at like California, for instance, and I think they have like 4 or 5 counties that don't have a provider or somebody where they can deliver a baby. So we've got that challenge. And then we have the challenge of, a lot of times women are, and this can happen in any community, but after that baby's born, they're really concerned about the baby. And a lot of times they kind of dismiss some of their symptoms. And people around them, we want our families to be healthy. So when something happens, we sometimes think, oh, it's probably fine. And I think that sometimes happens, even with as a physician, sometimes I'm like, I want my patient to be okay, but we have to be aware of, these are warning signs, and we have to investigate further. So, and we know that about 47% of the maternal deaths happen after they've gone home. And so, as we've said, I think there's some great ideas that we can do to face that challenge or to meet that challenge as far as like postpartum, calling and visiting and things like that. But that's the challenge that we see. And also, I think the access to care part, I think a lot of times there is some access, but people don't know. Like Dr. Case had said, they didn't even know the person who was in the emergency that she was there, that the hospital was there. And then also, what we're really trying to highlight too is our health departments. We have health department units in every county, and I don't think all of them are doing OB right now or prenatal care, but we're trying to expand that. But that's definitely an issue. And then we talk about the workforce, and that's been talked about a lot too. And I know I've heard somebody earlier to say, we're going to have, we need to have nurse midwives. We want to incorporate, see what we can do working with doulas and having enough OB providers, obstetricians, community health workers. But I also, in thinking about that, I really think we need to get away from our preconceived ideas. Because I do think there's been some resistance. I know I've seen it, before, heard it before. You think the midwife gives better care than me? When they see that the numbers are better in states that incorporate or work with nurse midwives. So, and no, that doesn't mean they give better care. It's just a team effort. So I think if we can, and I was talking to Nicole Fletcher, I don't know if she's still here, at a meeting, there she is. And we were talking about, I just was saying, there are some doctors and maybe nurses who think, oh, I don't know. They've not had a great experience. Maybe they felt like the doula was oppositional to what they wanted to do. Or the doula has felt like the doctor didn't, do. So, but she and I both agreed that's an opportunity for conversation and communication. Because how many times do we think somebody's against us? I've happened to my husband before. I was like, you're just doing that to irritate me. No, when I asked him why he did that, he has a good reason. And when I heard why his reason was, then it made sense. So I think communication and trying to see ourselves, how can we work together as a team instead of saying, oh, here's the doctor, we need to be working together and kind of, like I said, being aware of each other's strengths and also, assuming the good intent of the other people that we're working with.
That's a great point about sort of building out that ladder of care, as we call it sometimes, because we are so rural, we are never going to have a delivering hospital in every county, but we can strengthen those community healthcare workers, doula access, particularly the nurse midwives, all the way up till you get to people like Dr. Greenfield. Dr. Greenfield, your maternal mortality view is really one of the things that inspired me to lean in here, because it concluded that 91% of the maternal deaths, and I'm looking at Dr. Manning, in Arkansas are preventable. That is tragic, but also makes me very hopeful. It makes me feel like we know what to do. What would you add to what Dr. Chandler said?
So I think it's important for everyone to understand what we're talking about in terms of preventability and the maternal deaths. When we say pregnancy-related deaths, we mean those moms, something in that series of events that were caused by pregnancy ultimately resulted in that mom dying. Said another way, if mom were not pregnant, she likely would not have died. Now, there's another group where mom may have died because a tornado hit her house. That's a different category, okay? So we separate those. So what we're talking about, when we say this 91 to 92% are preventable, those are the pregnancy-related, and in those, the simple answer is heart disease, infection, hemorrhage, bleeding, those types of things. But the preventability, when we're looking at it and when the committee does its work, it really does a deep dive to see where there were opportunities for prevention. And that prevention can extend from a host of things that have been discussed today, from engagement to prenatal care, continuation of care, care that was provided by the providers, care that was provided by the facilities or systems. So it's across the spectrum. Each of us here has a vested interest somewhere along the way to impact preventability. So it's not just a patient, it's not just a doctor thing. It's a community, it's a patient, it's a family, it's a system issue.
Thank you. Janet. At the middle of all of this is kind of a mess for Medicaid, right? You said 58% of all births in the state are on Medicaid, and it is complicated to try to get on these benefits, to transition these benefits. Even if they're there, people might not know. Right now, there are only 2 states in the whole country that haven't already or aren't moving towards extending Medicaid for 12 months postpartum. Why not just do that?
Well, it's an education and an access issue. So with Medicaid and the expansion of Medicaid that began in 2014, we really have the coverage. We need to do a better job of getting our Medicaid beneficiaries enrolled, and then education on what the programs are to make sure they're in the right program during the birth and after the birth. So we do pay for over 50% of the births in the state, and I think we have an opportunity to really grow their education, their knowledge, and their access.
So you're saying coverage is there, and actually we should, if this works properly to really, smooth the process, the transition, we're going to do a better job of closing the gap than if we had just extended it.
Yes, that is one of the charges in the executive order, to immediately look at enrollment and the enrollment process and streamline. And the team at Medicaid and Health have been looking at that, and then looking at different ways to automate as much as possible to make it as simple, and not to do it on day 60, which I hear a lot from moms and providers, but really doing it and moving things upstream to be more preventative.
I love that. I mean, I can barely read my insurance bills, and that says something. All right, Secretary Putnam, Human Services already offers a lot of supports, a lot of different programs like Life 360. Tell us a little bit about the impact some of your programs are having and what your goals are.
Sure. Well, the Maternal Life 360 is relatively new, and we have several programs that have already been approved. We have several others who have applied to be part of the Life 360 program, but it's essentially a program where the woman who is participating in expanded Medicaid can be part of this Maternal Life 360 that is based at a hospital and has a follow-up home visiting program for about 2 years. So the program will actually incorporate home visiting and additional care and additional connection to services as needed. And so we recently received approval to serve to serve all women, basically, in the Maternal Life 360 program. Beyond Life 360, though, we also have specialized women's services, and that we haven't talked a whole lot about substance abuse during pregnancy, but our specialized women's services allow a woman to receive residential substance abuse treatment at the same time that she is pregnant and parenting, and does not separate mom from baby or children, and allows them to not just to go through the pregnancy and get healthier and get help, but also to mitigate some of the issues that she may have with parenting, and some of the the things that maybe she's missing in some support services. But so we've got those two opportunities with Life 360, the maternal version, and then specialized women's services. But we're looking to partner to expand, what connections do we have throughout the communities.
And speaking of communities, Secretary Mallory, as said, we're never going to have a hospital. We're always going to be really rural, and my understanding is that community healthcare workers need to play a bigger role if we're really going to address this. Help us understand what that looks like, how we get that happening. I hear people say, oh, healthcare workers, then you hear about the community health center. What does it actually look like to boost community care to close the gap?
So, our mission statement at the health department is to protect and improve the health and well-being of all Arkansans. That's tough. But the way, part of the way we do that is with our local health units. We have one in every county. Some counties we have more than one. In a number of those counties, we do maternity care. But the reason we do maternity care is because there's not the level of services in those counties that there needs to be. We are a gap filler. We have to be really careful that we're not seen as competing with private providers. Now, we need to look at those counties where we don't provide services because a lot of things have changed. And do we need to provide more services than what we provide now? What we're looking at in those counties, not only, do we need to expand services, but in those pilot counties, we had a large stakeholder meeting last week at the state level. In our pilot counties, in our 5 pilot counties throughout the state, we're also having stakeholder meetings in those counties to identify what the gaps are, to identify the services that are available, and where we might, if the gaps that are identified, can we fill some of those gaps, or where are the resources to fill those gaps? We're also working with other providers. We're working with Baptist and UAMS with their mobile health units. Where do we need those? How do we incorporate those with our services? We're also we don't do any telehealth right now, and we do know that we may need to expand in the telehealth arena. But what does that look like, and how do we do that? We're also in the local areas. We want to work with the schools. We have certified health nurse specialists. We have certified promotion specialists that are in the schools. They work with those school nurses. So how do we work with nurses there? What do we? With Heartland Forward, we are working on the community health worker piece with Representative Johnson and our other partners here. How do we expand the role of community health workers and doulas? And where do those fit into what we do, as well as what's done at the community level?
And can you just clarify, in those communities where your health center does offer maternity care, what exactly does that look like? Who's providing what type of care?
I'll leave that one to Casey.
Okay. Okay, so in those counties where maternity services are offered, so that usually starts with a pregnancy test appointment, and the individual, of course, comes in. They want to know if they're pregnant. If the test is positive, then before they leave, they have an appointment for WIC services for expecting moms, and then also for a maternity initial appointment, which starts that prenatal care. So the tests, the lab work that needs to be completed, the educational components, it starts at that visit.
And Casey, you also ADH also oversees family planning, right?
Yes, ma'am.
I strongly believe that one of the best things for children is for their mothers, for their parents to be ready to have those children, and I strongly believe in a woman's ability to choose the timing and spacing of her pregnancies. What role do contraceptives play in this?
So as part of the pilot project that Secretary Mallory just talked about, and the executive order, some of the initiatives, so one thing that we're going to look at in our health departments, I just talked about pregnancy testing. That is a good indicator of the next service needed, or maybe the main service that's needed. So we have all types of individuals that come in, maybe for a pregnancy test, maybe for that family planning appointment, maybe it's just to ask some questions of a healthcare provider in a safe space. So no matter the purpose, they're all going to get the education around contraceptives and what best fits their current situation or their next year, next 3-year goals. So if that pregnancy test is positive, then we start the services just like I discussed. If it's negative, it gives us an indication we know that person is sexually active. At that point, education starts, proper birth spacing starts, education starts around contraceptives. So that prompts the conversations, and that opens the door to that patient-centered counseling and proper spacing discussions.
All right, and speaking of education, Jacob, what role does the Department of Education, what are the opportunities for you here?
So I think one of the opportunities, and when we think of education, we always kind of think of teaching, but there's also some of the learning. And one of the things that I've definitely learned as we started working with this committee is there's a lot of opportunity to make sure some of these silos are becoming interconnected. And one of the common denominators that are in all of our school districts is access to the school nurse and making sure the nurses that many students will come and confide in or know what's happening in the students' families and lives and what's happening in their neighborhoods have access to a lot of this information, and we need to make sure that they're have an active seat at the table when working on making sure that we're doing proper family planning and working with school nurses and making and school counselors and making sure everybody's on board with what's happening and is informed.
I'm not trying to get too spicy here, but I know sex ed is controversial, can be controversial in Arkansas. Do you see a role? Does sex ed get brought into this conversation?
Well, and that's where I think as we go through this committee and look at recommendations to review our health education standards, are they robust? Are they doing a good job? I like to look at data. We talk about the percentage of infant mortality rates. When you look at the percentage of teen moms in schools, we're averaging about 600 a year as a state, right? Is that a number or a metric that we think is too high, too low? Those are some of the questions that we need to ask. But there's a reality about when we do find out we have some teen moms, what happens to them, right? They're not finishing school. So part of that education, whether it's sex education, health education, it's about education as a whole to make sure that if we do have teen moms, that they're able to still meet their future aspirations and life goals as well. And I think that's where we need to start having some deeper conversations about what do those programs look like? Where do we see opportunities to have stronger conversations?
I totally agree, because the best way for that mom to be able to take care of her babies is to be able to take care of herself. Dr. Chandler, you brought up midwives. I'd love to dig into that a little bit more. And maybe anyone who'd like to, please weigh in on our ability to really pull that lever, because my understanding is currently there's nowhere in Arkansas where you can train to be a midwife yet.
Well, I believe that's changing, right? That UAMS is just now starting a program. So I don't even know when that started. Pretty recently.
No, so it's it was passed.
So can
Okay, it's not yet. Okay.
No, it'll be operational in 18 to 24 months, I believe, is what UAMS
Yeah, that's
testified
right.
to.
Okay. Yeah.
So can we talk a minute about the differences in midwives?
Yeah.
And Dr. Greenfield can speak to this too. I think we use the term midwife interchangeably, and at the department, we license 2 types of midwives. One is a certified nurse midwife, which has a nursing background, and they're advanced practice nurses. And then we also license lay midwives. So a lay midwife goes through a course, but there's differences in those types of midwives, and I think we need to start talking in that kind of language about the differences in the midwifery requirements.
Sure. We have a population of healthcare providers across the state, certified professional midwives who go through various stages of training, and they perform a lot of the out-of-hospital births. So when we talk about...
Do you mind just, for the audience, what are the qualifications of a certified midwife then?
Well, they go through a process...
Are they an RN? Or they can be a midwife without being an RN?
No, they're not an RN. It is a pathway, and there are a number of different pathways of MEEC certification and an apprentice model as well, and that ultimately end up with licensure and a process of supervision and direct observation, as well in some cases of brick and mortar education as well. But that program historically it was called a licensed lay midwife, but really, and that is, I would say, I'm not a legislator, but I think that's sort of how it's codified in the legalese. But the proper term would be a certified professional midwife. And we have a population, and they provide a small number of births, out-of-hospital births, mostly out-of-hospital births across the state.
Yeah. Is there any argument against training and using more midwives?
I think when we talk about having trained healthcare providers, it's important to recognize that patients will frequently, a lot of this will be driven by what patients want and respecting patient autonomy. Some patients will, and most patients will largely choose a medical model and choose for in-hospital births, and that's certainly what the data shows. But we have, and I can't quote the exact number, but somewhere around 300 out-of-hospital births that are for low-risk patients, properly selected, and can get good care in that setting. But that is a difference between that model and the nurse midwife model, which is typically an RN or APRN who then goes on. So it's important to that. And then we mentioned doulas having an important role, but they're not medical providers. They are the support personnel, support team, and I shouldn't say personnel, not meaning to offend, but they're support for the moms through the birthing process as well.
And so for low-risk moms, it can be a really safe and impactful intervention.
So my first daughter was delivered by a certified nurse midwife, and I think what we
No
are
epidural.
No epidural, yeah.
I don't know how you do
Sorry,
it.
now you all know too much about me.
I'm a hospital girl.
We were chatting on the way up. I think what we are all very interested in doing is expanding all of the opportunities for bringing in other partners. We know that we need to respect, what a woman wants in her birth experience and the family that's associated with that. But I think, and then subsequently I had 2 more daughters, and they got harder as they went along, so they weren't nurse midwives, and so I stopped at 3. But the experience, I think, is very, the women need to be able to have some additional options, and that's the conversation that we are having, that we've invited everybody in this room and beyond to have with us, as well as how do we logically, thoughtfully, intentionally add to what we're able to offer by way of resources.
And if anybody wants to learn more about midwives, my friend Kara Osborne is up here in the pink shirt. She has written a report about the efficacy of midwives for delivering rural care, with Alaska as a fascinating case study. So come find Kara. Dr. Greenfield, maybe back to you for a second. Part of the executive order is a pilot in 5 counties. Can you tell us a little bit about that? Is there anything there that you are really excited about that you think really could be scalable?
So we had our first kickoff meeting, or our first pilot meeting in Garland County. And I think it's important, that was a smaller room, but many ways very similar dynamic, except it was a back and forth. And we had folks from, for example, the people who we had in the room, chief of police, county judge, school superintendent, hospital executive. These are the folks who typically may not be in the same room at the same time having these conversations. But to drive these points of education, ways that we can be innovative in technology. And on the point of education, I think it's important to recognize that the education is not a top-down education model. It's a dynamic, because I am not a Medicaid expert. I may learn something. I am not an education expert. I may learn what that school needs. So it was really important. And so this is an opportunity for us to get to the county level to find out exactly what the county's needs are, because they will frequently be a voice or a conduit that is trusted in that community. So whatever comes out of this, we will need people in the community who are trusted, so that the message is direct, it's tailored to them, and it's heard.
Can I add to that too? At that meeting, Casey might have been saying the same thing. What was really neat is that as they were there, like, oh, I didn't know you did that. Oh, I didn't know you did that. Like, somebody was like, how can our women get prenatal vitamins until, if they can't afford it? Maybe somebody has insurance, but they don't have the expendable, to even go get the store and get prenatal vitamins. The health department has those, and people didn't know that. So just getting together was really great to share that information.
So I just wanted to add the 5-county pilot. I'll put a little plug in here. So we selected a county from each of our 5 public health regions. So if you want to be a part, we still have those local stakeholder meetings that Dr. Greenfield was talking about for Crittenden County, Phillips County, Scott County, and Polk, P-O-L-K County to go. So if you're interested or you have someone that locally that wants to be a part, please reach out to us.
That's so great about getting all the different stakeholders together, and that's one of the things that I think is going to be really impactful about this steering committee. And I also think there's a role for a lot of non-government partners, and I'd be curious what all of you, maybe each of you could weigh in, what role you think business, philanthropy, other stakeholders could play in helping solve the maternal health crisis here in Arkansas. Jacob looks deep in thought, so should we start here or there? You got one?
I'm always ready to have a conversation. One of the things that we talk about when we're looking at health education, I talk a little bit about teen pregnancies and looking at the data and seeing different regions of the state may have higher numbers and they need more targeted programming, right? And how can we get more sophisticated on data collection? Because a lot of it right now is just word of mouth, right? We don't really have a sophisticated way of making sure we have access and getting those kind of shared agreements across government agencies so that we're all having access to the same information. But I always go back to access to child care programs, non-government related access to high quality child care programs, access to early learning environments, access to literacy in a print-rich environment. One of my biggest aspirations or dreams is if we know moms will go in for their checkups with their babies to get their weights measured and their heights measured and get those normal checkups and shots, is for the doctor and all the practitioners to add, do you have books in your house or are you reading to your kids as part of that annual checkup or that quarterly checkup? Because if they don't, then if we had a sophisticated network with nonprofit, we can get them signed up for Dolly Parton Imagination Library. There's so much just evidence and research supports. Just having access to books will make kindergartners ready to learn when they come into kindergarten. And why can't we just make that part of our annual checklist?
Nice. Dr. Greenfield? Or we can go whoever would like to go. But.
So I think it's important for the non-governmental organizations to be involved. We have a number of organizations within counties that are very connected. 3 years ago, I had an opportunity to come up to Springdale to speak to the Marshallese community on this topic before we reached this high water mark. I would say, similarly, there are organizations within each county that are trusted, and even tapping into the faith-based organizations, because they will be very widespread throughout the state, and they are a good tool to be leveraged in this conversation.
First when I started thinking, I was like, and then a lot of ideas came to mind. But really, even at that recent stakeholder meeting, we heard from, I believe her name is Marisha DiCarlo from Children's Hospital, and she was sharing how they're doing a program called Love Notes. I don't know if you've heard of that, but it's more about relationships and refusal skills, and they talk about contraception. I think there's I think it's like 12 hours. And in 4 years, they've gone from 2 schools to 26 schools, and they have 26 schools on the waiting list. But she said part of that, they need funding. So, I mean, that would be an opportunity. And I just think about resources. I was recently talking to a community health worker, and he was telling me how he'll go to other parts of the state. He's in Northeast Arkansas, and he can direct people to lots of resources, but in his area, they don't have as much. So, you think about, it's great. I just was kind of looking at Northwest Arkansas and how you have the Rambler and then the, Razorback Greenway and all the, I don't know if that's partly funded by private, but, to have open spaces, to have recreational spaces in all parts of the state where people can take their kids out and they can get the exercise they need. And then lastly, I would just say, one of the things we should try to do, a lot of the things in our health are things that we can do for ourselves. But sometimes people will need the resources, and they need education and they need support. So we need to do what we can do to help people do the right things. And so then when Dr. Pearson said that about revamping the food industry, I was like, that would make, if there's anything that we can do in that area to really change the culture on how we eat even, like eating at home more, we're also talking about people going out to eat just fast food 4 times a day in the Northeast the community health workers were telling me about this and how they're trying to help them with, with their diet and giving them advice or education. But also they were talking about how, because they didn't have resources, sometimes they were taking money out of their own pockets. So I just think there's a lot of opportunity.
So I think it comes down to the trusted community partner. Medicaid is a statewide program, but we have a responsibility to be in every community for any Arkansan that qualifies. And I really think putting everyone in the room, such as this and what we tried to do last Monday, and that we will continue to do with our subgroups of really tackling how do we do, it's continuous process improvement. Medicaid, you do one thing, you see how it works, then you make some incremental change, and you keep moving the needle forward is the goal. And I think having that conversation and then thinking outside the box, just because Medicaid pays for half the births in the state, that's our responsibility. We take it gladly, but we need to do it better. But we can't do it alone. And so things that I can't pay for that I need partners in the communities to assist us with. So I think there's the fact that what started out about 14 months ago as about 5 different meetings a month with different groups that I just kind of butted my way into, to us having this conversation now to really have that continuous improvement.
I agree with everything that's been said so far. But, my team has heard me say this a lot, and this group has heard me say it a couple times. There are so many amazing resources in this state. There are so many incredible partners. I'm from Florida, I came here from Kentucky, and now I'm here in Arkansas, and I couldn't be happier to be here. It really is getting everybody in the room and making sure that, you heard Dr. Chandler say this earlier, I'm a huge believer in this, you have to assume positive intent of the partners who are in the room with you. And so I think getting the community partnerships together, building that trust, assuming positive intent, even when people prove you wrong sometime, that's okay, continue to assume that positive intent. But the other part of it is not caring who gets the credit. And I think that we have an incredible group of people who are interested in helping with this effort. Our complicating factors are in government that our funding streams come to us in many different ways. The other thing that I want us all to just sort of hone in on is our children and families don't come to us in pieces, but we're forced to plan and budget for them as if they do. So the more we can talk together like this and in the room, the more we can come up with creative ways to, legislators, close your ears please, bypass policy that we need to fix and then fix it. But I think that these are the partners who need to help tell us how that can happen and offer resources to help us continue to build out the system that is a larger system of care and not just Medicaid, not just Department of Health, not just education, but collectively, how do we better serve our children and families?
And I think that actually goes back to the case for investing in maternal health, because Kara likes to say this is kind of the greatest window of time to impact change, because it's often the time in a woman's life where she sees a doctor most consistently, and it's your best opportunity to change the trajectory of that woman's health and thus that family's health. So I really agree with that. Secretary Mallory?
Okay, I'm going to answer that question in a little different way. Instead of how can businesses partner or what can they do for us, I think they need to look internally. Every business has pregnant women and women working for them in your organization. Look at those pregnant women and ask the questions. Do you have a doctor? What can I do for you? That's what I think we need to start with, and that's taking care of our own. And I'm sitting here, we need to do that at the health department. I'm sitting here thinking about it. We don't do that enough. How can we help you? And we really have to care. I want to say one other thing. And Dr. Case, wherever she's sitting, brought this up earlier. Talking about intent, we need to realize that we're all in this together. And, we need to have patience with each other, no matter from what perspective we're coming at it from. And, I know at lunch that was, you could read the faces in the room, but we really need to figure out, we're all in this together, how do we work together to get it done?
So I'll just echo most of the other comments. It takes everyone, and that's one thing I really enjoy about serving in the Department of Health and through our local health departments, because sometimes you meet people at their best, sometimes you meet them at their worst. And so I really enjoyed the conversations and just the thought process around some things that I don't even think about during the day, someone has to think about for the next minute or the next 5 minutes. So it takes all of us to make those resources work. And, you know, Pearl, and I've talked about this for a long time, many of you in the rooms. So I enjoy filling in those gaps, seeing the relief that comes to some of our patients when they didn't know what they were going to do, and suddenly it's like, I have a resource, hang on, let me connect you. So I think that's the important part. That's the partner piece of it. And when we all come together, one can do a little, but many can do mighty things.
I know we are coming up on time, but we started late, so I think we should get to squeak out one more question. And feel free to leave. But sometimes when I talk to people about fixing maternal health, it feels like the rubber really meets the road on the reimbursement rate. And you spoke about how you're in this awkward position where you sort of you want to step in and provide care, but you're trying not to disincentivize private practitioners who actually think they can make a living from providing these critical services. So how do you balance that? How do you balance incentivizing private providers to come in, and how are we going to get the reimbursement rate up?
So I'll start with reimbursement rate. I do think one of the things we committed to on the committee was looking at the reimbursement rate. We've been pretty vocal about that. A global delivery fee may not work best for Medicaid. We really want to be able to know who goes.
What does that mean? Does everyone here know what that means? What does that mean? A global delivery fee?
A global delivery fee is you get paid at the time of delivery. Doesn't matter how many prenatal visits. Doesn't matter if you go to postpartum. But if you show up in the ER or in your clinic or practice,
so you just do the catch in and you get all the.
Pardon me?
You basically just catch. And you get no.
Right. Yes, I'm not going to go there, but okay. Yes. So I think one of the things we've looked at and we've talked about in the group setting and really trying to put a financial model together, any legislators beside y'all just bear with me, is really looking at how we do and incentivize prenatal visits and a postpartum visit without penalizing the delivery. Recognizing that in a rural state, you may see 2 to 3 doctors at the time of your care for prenatal delivery and post. So recognizing that and trying to create some type of model that Medicaid can reimburse. And so in an ideal world, we would pay for 7 to 8 prenatal visits for a low-risk pregnancy, pay a delivery, pay for a postpartum visit, and then for a high-risk pregnancy, pay for some extra visits. So we're looking at that. I think we've got to really put pencil to paper and see how we can address it. And I think that was part of the charge that we took for access to improvement and with Medicaid improvements.
Anyone else want to weigh in on that? No.
They don't want to comment.
Well, thank you for that. And thank you all so much for taking the time. I hope that all of you leave here today as energized as I do about this conversation. I just really believe that investing in mom is the most important intervention we can make, because if we can make sure mom is okay and healthy, that is the best thing we can do for our families, our communities, and our state. So thank you all.